introduce you to a little bit about this webinar series. This is a series that is presented by the Toronto Dementia Research Alliance in partnership with the Alzheimer Society of Toronto. And it discusses recent updates in dementia research and highlights dementia research studies that are occurring across Toronto. For today, we have a little bit of a different plan than we usually do. Today is really all about looking at disease-modifying therapies for Alzheimer's disease in Canada and what they mean for people living with dementia and their families. A little bit of what you can expect from today. So there will be some introductions just so you know who is on the panel. Be looking at what the therapies are, who might be eligible, how access works, what this means for the healthcare system, some reflection with a lived experience, opportunities for questions, as well as closing remarks. As I mentioned, I'm from the Alzheimer Society of Toronto, so I just wanted to give you a little bit of information about who we are. So, the Alzheimer Society of Toronto provides information, education, and support to people who are living with dementia, as well as their family and friends, healthcare professionals, as well as general public within the M postal code. We do service all dementias, and a diagnosis or referral is not required to access any of our programs and services. Our services are offered in person as well as virtually through Zoom and the ALS Educate e-learning platform. So if you wish to learn more about all of our upcoming events, please do visit our website at www.alz and take a look at our calendar of events for our upcoming offerings. I'd also like to take some time to introduce you to the Toronto Dementia Research Alliance. So established in 2012, the Toronto Dementia Research Alliance, or the TDRA, is a collaboration among the University of Toronto, Baycrest, the Centre for Addiction and Mental Health, Ontario Shore Centre for Mental Health Sciences, Sunnybrook, Unity Health Toronto, and the University Health Network. Together with its partners, TDRA aims to strengthen the link between basic science and clinical research to better understand, prevent, and treat dementia. So I'd like to take this time to pass this to Victoria Telford from TDRA to tell you a little bit more.
Thanks, Julie. Are we able to pop the slides on the screen quickly?
I didn't realize it was not showing. Thank you so much.
No problem.
There we go.
Just waiting. Okay, perfect. So hi, everybody. My name is Victoria. I'm a research officer for the TDRA. Just in case nobody is familiar, we do have a research studies portal that's available on our main website. So it hosts dementia research studies that are open for participation across the city. Like I mentioned, it can be accessed on our main website under the Participate in Dementia Research tab. All of the studies are outlined in plain language for people to browse. And if you don't find a study that you're interested in or you're having trouble finding one, you can fill out a screening questionnaire and that will help match you to a study. Could you go to the next slide, please? So there are two main pathways to be connected to a research study. What you can do is, like I mentioned, browse the research studies in plain language on our website. You can also fill in some of our filters online. So you could fill in your age or the location that you'd like to participate at, and then there are studies that will pop up that are recommended for you. You can self-refer to those studies, and your information is sent directly to the research study team. Otherwise, you can fill out a screening questionnaire with some demographic information and your specific preferences, and you will be sent study options from our study team based on your preferences and eligibility. If you're interested in browsing the research study section of our website, I'm going to pop the link in our chat and you can visit it there. Next slide, please. So I want to take this opportunity to briefly introduce our panel of speakers today. We're very lucky to have four people speaking this afternoon. So Dr. Carmela Tartaglia is a cognitive neurologist, the co-director and medical lead of the Toronto Western Hospital Memory Clinic, and a professor of medicine at the University of Toronto. She's also the executive director of the TDRA. We have Chad Mitchell, who's a health policy expert and senior associate at Global Public Affairs. We have Kara Sullivan, who's a retired high school teacher, and she's a member of TDRA's Lived Experience Advisory Partners. And Paul Leah, who is also a member of TDRA's Experience Advisory Partner. And he is someone who is living with vascular dementia. So I'm going to pass it over to Dr. Tartaglia now. She's going to present some information about disease-modifying therapies.
Yes, thank you. And thank you all for joining us and, to talk, learn a little bit about what's going on in the landscape of Alzheimer's disease in particular. I will just move. These are my disclosures. I have some grants. I do consultancy for some companies and I run clinical trials, mostly in Alzheimer's. And I think it's important to understand what is Alzheimer's disease. As you probably know, or maybe don't, Alzheimer's disease is a disease that is made up of changes that happen in the brain. And those changes are amyloid plaques. So these clumps of amyloid, get stuck to the brain. And there's these neurofibrillary tangles, and those are made up of tau. So two bad proteins accumulating in the brain to give you Alzheimer's disease neuropathological changes, so the disease in the brain, and that is what is associated with the changes that we see in people. So the Alzheimer's disease, more the syndrome. So a few things to understand is that Alzheimer's disease does not start the day that a person starts to complain about a symptom. This disease builds up in the brain decades before. So if you think of this part where, I don't know if you can see the MCI, mild cognitive impairment stage, is when a person's, maybe has complaints, you can detect the disease, but the disease has been going on for decades. But of course, if you look at that MCI, and I don't know if you guys see my cursor. Can you see it? No. Okay. But the MCI, you can see there's a big timeline between MCI and dementia, right? And that's, that could be a decade. That could be even more than a decade. But during all this time, there's disease accumulating in the brain, and it is not normal aging. And we can actually detect. So this is time point 0. You see the dashed line. All the time before, there's accumulation of this amyloid and the tau in the brain. Your brain is resilient. You can compensate for that, but it's still causing some damage that eventually will show up and give you the whatever memory problems, changes in personality, changes in thinking, whatever it's going to do. So what is amyloid plaque? I'm going to focus on this protein because this is the protein that these new drugs are going after. So you're making amyloid all the time. For some reason, in some people, it starts to, clump together, right? And, it forms something that little clump is actually, we call it an oligomer, is not good. It's toxic to the brain. And then these clumps get bigger and bigger and bigger, and eventually you end up with that amyloid plaque, okay? So this is happening all the time if you have Alzheimer's disease. And the important thing is that although we think everything is Alzheimer's disease, it isn't. And because of that, it makes us, when you realize that it's not all Alzheimer's disease, it makes you understand and realize that you actually need to have a diagnosis, a true, accurate diagnosis that you actually have Alzheimer's disease as the cause of your symptoms. Unfortunately, in our society, Alzheimer's and dementia have been kind of used interchangeably, which is a problem because now we have all these people who think I have Alzheimer's disease, I have dementia, which is not true because I told you could have Alzheimer's disease in the brain and have only mild symptoms. Also, a problem is the fact that everybody who has got dementia thinks they have Alzheimer's disease. And if you look at this pie chart, you can see that, yeah, Alzheimer's is a big chunk, 40%. But there's all these other causes that also can give you dementia. So another thing I want to talk a little bit about before we start talking about treatments is that when we think of a treatment, there are different types of treatment. So, if you get a cold, you can take some neocitrin. It's not going to change anything to your cold. It will still last the 7 days, but you will feel better during the time that you have the cold. So that's what we call symptomatic treatment. But if you ended up taking something that actually shortened the length of that cold, that would be called a disease-modifying treatment. Cancer has a lot of these, luckily, right? Where we can give a treatment and we can actually change the course of that person's illness. And that's great for cancer. Even better is treatments that, even over time, you actually get more and more benefit as you take the drug longer and longer. So that distinction is important because of what we're going to talk next in terms of Alzheimer's disease. So how do these therapies work? They're actually monoclonal antibody against tau. So you inject them, they're going to go into the brain and try to get the amyloid out. That's what an antibody does. And, for some drugs, you have to give this every 2 weeks. Other ones, you have to give them once a month, but that's its aim. It's just trying to create like an immune response, basically rev up your inflammation system so that it attacks the amyloid and clears it out of the brain. And we have 2 drugs that have been approved in the world. In Canada, actually only lecanemab has been approved, and we'll talk more about that. But the drugs are similar in that they're attacking amyloid, but they're doing it slightly differently. So lecanemab is trying to get at the earlier forms of amyloid and maybe a little bit less towards the plaque, whereas the donanemab, the other drug, is really focused on that plaque. So, like I said, lecanemab was approved October 27, 2025. Took a long time. You may have heard in the US it happened in July 2023, but it got approved. It's for the treatment of mild cognitive impairment or mild dementia due to Alzheimer's disease. You have to confirm amyloid pathology. As I've already talked about, we have 2 pathologies, but you have to confirm that you have one of them. And you cannot take it if you have this genetic, let's say, flavor of ApoE44. And we'll talk a little bit about that, but basically they were the patients who had the highest risk. This is not a common, it's not common for you to have, like, let's say chocolate as your flavor. Most people, you can have different versions of this. So let's say you have vanilla, strawberry, and chocolate. A lot of people will have strawberry, or, vanilla strawberry, or you might have vanilla chocolate or strawberry chocolate, and all those are okay. But if you have chocolate, you can't get this drug because the risk was deemed too high. And we'll talk about what those risks are. So what does lecanemab do? Like I said, it basically, gets injected, revs up your immune system. This is your immune system, microglia, and they start to fight those little fibrils, those little things of amyloid, and get rid of this plaque. Or, if you get rid of the fibrils, there's less of these plaques that are going to be formed. Those are those little the big round blobs that you see. And so what does it do? Well, like I told you, it's going to go after your amyloid. So in blue, you see somebody who didn't get that drug. And in yellow, you see the people who got the drug. So it does its job. This was at 18 months, basically took out most of your amyloid. But at the end of the day, you would probably say, okay, great, you took out my amyloid, but what does this do for me, right? And so this is data from the 48 months. So it showed that after 48 months of treatment, it slowed your disease by 30%, right? And so what does that actually mean? Well, one, it means it didn't stop the disease, right? Because if it stopped the disease, you'd have that nice black line across the top, but it doesn't do that. But it slowed it down. So if you see there that 9 to 12 months, okay, and this is on a scale, it's a clinical dementia rating scale, a clinical dementia rating severity scale. So basically, if you look at that number 9 to 12 months that you see this like that red line, basically, if you take the disease modifying drug, this lecanemab, for 4 years, you are at the same place as somebody who didn't take the drug when they're at 3 years. So it saves you about a year of progression. Okay. Now, the purple and reddish lines, they were not placebo. And that's what we always want, a drug trial that gives you drug versus placebo. That's the best type of evidence that we have. But people aren't going to stay on a placebo for 4 years. It's really hard. So those two pink and purple lines, they were from a different drug trial. Sorry, they were from a different trial. It was an observational trial where patients enroll and they're followed, and they did it for altruistic reasons. They just wanted to donate to science, to research, and that's what they did. So they're followed every 6 months, and they do all the similar tests as in this drug trial, but they did not get intervention. But you could imagine that's like the best people, right? Because no matter what, if they progress too much, they actually would have not even been there. So I would say that the difference between these two lines is actually maybe an underestimate. Oops. Did we lose? Maybe we lost.
Just a second.
My connection blinked out a little bit.
Okay, maybe. All right, there you go. So as I was saying, this is basically that after 4 years of treatment, your cognition and function is about 9 to 12 months better than it was if you weren't on the drug trial. So it wasn't just on this clinical dementia rating scale. This is actually from the company. So it showed slowing in cognition and function based on that scale. It did drop the amyloid. There was some slowing of cognitive loss based on this test that we do. You might know the MoCA or the MMSE, but there's other types of tests that we use. There was a test looking at how well you perform your activities of daily function. There was some slowing there. There was quality of life that was much better in the people that were treated, and the caregiver burden was 38% less. So at least all the data seemed to converge that there was some benefit to being on this drug. And when we think about, going, like, who's going to be able to get the drug, okay? And what does that mean? So this is the clinical dementia rating scale, and you don't have to, know all about it, but it basically assesses different factors of your life or aspects of your life. It will assess how well you're doing with your memory or orientation or your judgment or your community affairs, home and hobby, personal care. And if you're healthy, then you get a 0 score. It means you have no memory loss, you're fully oriented, you solve all of your problems, you're independent, you do your hobbies, you take care of yourself. If you have mild changes, you get a 0.5. You could have some forgetfulness. You're fully oriented, but every now and then there's a bit of a slip. You have slight impairment in problem solving. You might have some slight impairment in your community affairs. You could have some, less interest in some of your hobbies, but you're fully capable. right? You are independent. That's what 0.5 means on this scale. When you have a little bit more impairment and you need a little bit of help from somebody, then you get a 1 in each of these factors. And that we call mild dementia. Because if you're not independent and you have some dependency, even if it's only a little bit, then that's how we define dementia. So you could have moderate memory problems. You need some help maybe doing your finances. You need a little bit of help maybe, organizing your shopping list. You're still doing very much on your own, but you aren't fully dependent. And for that category, you get 1s for each of those different categories. And those 2 groups are the only ones who are allowed to get this drug. Anything more severe, this drug is not for them. So if you have moderate or severe where you're needing a lot of help, this drug is not for those people. And so when we think about a difference of 2, right, after 2 years, you could imagine that if you're at 0.5 or you're at 1, if you're on 0.5 on each of those measures, or you were at 1, well, it's a big deal to even gain 0.5 because you went from being mildly impaired and independent to actually being demented and needing some help with something, even if it's not that much help. So, sometimes people say, well, do these numbers actually mean anything? Well, if you're the person and you were independent and now you're dependent for needing some help for things, I would say that's pretty meaningful to you. But there are risks. These drugs have pretty significant risks. So in the drug trials, there was some brain swelling in 12% of patients. There was some brain bleeding in 17, and these are small hemorrhages, but no matter what, this is not insignificant. And there was some drug reactions. These are very common when people get an infusion. You can end up with some fevers, chills, or rash at the time that you had the reaction, and they go away. So, these drugs are not for everybody. I've just said there's actually a very select group of people that would, because I've told you this drug has side effects. So of course you only want to give it to people who actually are at high risk of benefiting for the drug. Otherwise, they would get all this risk and not that much benefit. So who can get this drug? The drugs are for people who are at mild stages of disease, early mild cognitive impairment or early Alzheimer's. We have to prove they have amyloid. We look at their brain MRIs. They have to have less than or 4 microhemorrhages. They cannot have any blood on the outside of the brain, which does happen to people. I've already told you can only have 1 chocolate scoop. If you have 2 chocolate scoops, you can't get this drug. You can't be on a blood thinner, and you have to be medically stable. And of course, it's important to, like I've said, you have to be mild, right? Mild cognitive impairment or early dementia. So you can be forgetting recently learned information. You can be repeating questions, losing track of dates, losing items. People sometimes do make some, have some decision issues, but oftentimes our patients are said, well, this is just normal aging, but it's not normal aging if these are consistent problems. Everybody can have an off day, but if you're consistently forgetting names, places, if you're having more difficulty following instructions, or there's some, significant change in your mood, or your apathy, you're less interested in things, then this needs to be investigated, and you could have mild cognitive impairment. And again, because these drugs are only for people in the mild stages, then of course it's important that people do get investigated so that, they could, maybe access the drug if it's for them, if they choose. But it's also important that people who are in the more advanced stages of Alzheimer's disease or other types of dementia, they're not going to be candidates for this drug. So, it's also important to understand the drug has limitations in what it can do. It was not a cure. So people who are too advanced, it's deemed not beneficial for them. And I've already talked about that, so we don't need to belabor. This is what we look for in MRI on the left. These are the microhemorrhages. You see, like there's about 6 little dots there. 6 little dots. This person would not be eligible to get this drug. The one in the middle, there's a little line there that's black. That's called siderosis. They would not want to give the drug to somebody with that because they're at risk of bleeding. Somebody who has a lot of what we call cerebrovascular disease, all that white fluffy stuff, those people, they might be at risk of bleeding. So we have to really think twice. So this drug will not be for everybody. We can detect amyloid, so we can do lumbar punctures, we can do PET scans. This has been around for a very long time, and we can tell you if you have amyloid or not in the brain. There is now even blood tests that are available. They are not really as good as these, and I think we have to be kind of careful. They've just gone onto the market. They're not Health Canada approved. They're not OHIP covered, so you have to pay for them. We're not really sure how they're going to fit into, the landscape, but this is available and they will become better and better. And someday there will be screening for Alzheimer's disease, probably when you turn 65, just like we do for colon cancer and things like that. We're not quite there yet, but the future is coming. Remember I told you, you need to have there's one flavor where if you got 2 scoops of chocolate, you cannot get this drug. That's this genetic test, let's say we call it isoform or genetic version of apolipoprotein E. This is just a gene. It's a gene that puts people at higher risk if they have this ApoE4, even if you have 1. So that increases your risk of Alzheimer's. If you have 2, it increases it even more. But the problem is that in this case, with this drug, it increases the risk of bleeding too much. And so 15 to 25% of patients will have 1 scoop of chocolate, and that's okay. But 2 to 5% of our population carries 2 scoops of chocolate, and they cannot get this drug. And so what are the doctors going to look for to decide on eligibility? They're basically going to ask about how well you're doing. How independent are you, right? And make sure that you don't have any bleeds in the brain. Make sure that you're not on any anticoagulation, and obviously that you don't have the 2, 4 alleles of this gene. You're probably going to get some, testing, some cognitive testing. And it's not because the testing really dictates, whether you get the drug or not, but obviously, the better, people are doing, the better, we think, that at least they'll be able to preserve that. We actually do this other type of testing. So you probably know the mini mental or the MOCA. In our clinics, we do this Toronto cognitive assessment, the TORCA. It's just a different version. The drug has a certain burden associated with it because it's given as an infusion, and it's given every 2 weeks, and you need a number of MRIs to check. First, you need a baseline MRI because we need to know if you need any, if you got blood on the brain and you can't get the drug. You also need to monitor, right? Because you could develop these hemorrhages, you could develop the siderosis, and so you need an MRI before the 3rd infusion, which is at 6 weeks. You need an MRI before the 5th infusion, before the 7th infusion, and before the 14th infusion. And obviously, if they found blood, you would need more MRIs. The sequences for these MRIs are about 10 minutes. So, something to think about. There's going to be, the initial treatment is thought to be for 18 months at every 2 weeks, and then could go to once a month. So in Ontario, lecanemab is Health Canada approved. It's not OHIP covered, no insurance coverage to date. Hopefully that'll come soon. And so it's only available to out-of-pocket payers. It's $32,000 to $34,000 per year. Donanemab, which is another drug, same family, works slightly differently, as I told you, is still under Health Canada review. And I just want to highlight something, that there's so much reason to be optimistic in our area. This is like a drug development pipeline. These are all drugs that are being tried for Alzheimer's disease. And as you can see, it's huge. They're different colors. The little icons are different colors because they're targeting different things. The red is targeting amyloid, but other targets are also coming down the pipeline. So I think, I think there's every reason to be optimistic. And so this is, these drugs are the first of many treatments to come in the future. And I think that's it for me. I'll pass it on to Chad, right? And the questions at the end, or?
Yeah, I think we're going to save them for the end.
Okay, thanks.
All right. Good morning or afternoon, everyone, depending on where you're phoning in from, or sorry, virtually in from. I'm no longer using a phone on this type of platform. I'm Chad Mitchell, and maybe we'll advance to the next slide.
Yes, you have slide control, so you should be able to
There
move
we
it.
go. Things I didn't ask. So my conflict of interest slide, as mentioned in the introduction, I used to work for government as one of the decision makers for drug funding, for publicly funded drug funding in the space. I've also worked on various organizations that I'll touch base on in my presentation here. And currently, I am working for a consulting company called Global Public Affairs. So I'm also have some industry funding component. And we'll go to the next slide here. So, as as we all know, Alzheimer's is something many of us know personally. I know myself. I had a parent who actually stood up a novel Alzheimer's center here in Alberta. So the expectation was, of course, I'd go in and volunteer on there. But, through a parent, friend, or neighbor, and that's why we're all here today. And as the good doctor pointed out, is what is new is that this conversation is happening about a treatment option, a first time that we're having treatments that can slow the disease. And the key point to reinforce is that if they're used early. So I'm going to focus less on the drug itself and more on the practical question and that is, if the treatments exist, can a health system actually deliver them safely and fairly? So the short answer is not easy and not with some hard choices. So I'll give you a brief overview of the health or the drug approval process before funding by a public drug program is made. As a good doctor pointed out, right now there is a treatment option that has been approved by Health Canada. And that doesn't mean that people will automatically get funding for it underneath their insurance plans. What does mean is that it's been reviewed to make sure that the drug is safe and it works and the benefits outweigh the risk. And that has gone through Health Canada. The next step is that because we're looking at the value for dollars that government are spending, there's an independent committees set up, one in Quebec called INIS, and then for the rest of Canada, the provinces and territories participate in what's called the Canadian Drug Agency. And there's a group of independent clinicians and also a patient representative on there to give advice to provinces and territories on whether or not they should fund medication. And then there's also the provinces and territories, all of them gathered together, and this includes Quebec. They do a joint negotiation strategy with the drug companies before there's a final decision being made by each individual province whether or not coverage is given. So I'll get more into the timelines near the end of my presentation. the thing to remember as well, it looks sequential on here. There's opportunity for parallel reviews, and we are seeing that between Health Canada and the drug agencies and all that. So before I get into Alzheimer's itself, specifically, it's important to sort of understand the environment that provinces and territories are already operating in. Um, we're probably all experiencing some of the healthcare systems that are under pressure today. You know, capacity strains in the hospitals, emergency rooms, trying to get a primary care doctor, and of course, specialist care. Um, and at the same time, we don't have enough continuing care and long-term spaces to provide for everyone on there. That's why there's interest in this treatment on that slowing progression of the disease. There's workforce strategy shortages. That's another big constraint, as I mentioned in there. You know, this problem, of course, is magnified if you get into rural and remote areas where recruitment and retention of clinicians are it's hard to come by. Uh, Aging and chronic diseases. So, you know, our Canadian population is aging quickly, which means that hey, their health needs are increasing, so are their medication needs are increasing. And you know, over the next 20 years, our senior population is expected to grow dramatically. We're also dealing with mental health and addictions. All provinces are dealing with not only the addiction side with the opioid crisis, but also how can we have individuals aging at home who are experiencing that cognitive decline and often without enough support. Another reason why there's much interest in this medications. And on the flip side, there's also cost pressures. You know, healthcare costs are continuing to rise more than government revenues coming in. There's also some unfinished, what we call policy issues, and that add to this complexity. And this includes rules around private MRI clinics and what counts as what we call uninsured services where government pay for it. So once again, there's all provinces and territories are struggling with this competing pressure. So let's talk about MRI capacity. And also infusion capacity for these medications. So as I mentioned before, there's a exponential growth in seniors over the next 20 years. Right now, there are long waits remain a concern for MRI access, and you know, adding a machine doesn't necessarily equate to more access because you also have to train the staff, which I'll get into in a few moments here. There was a recent research study published and included clinicians from Sunnybrook and other academics, and they modeled out, you know, what does access look like and what would be the capacity in our healthcare system to provide these medications for individuals. And they estimated less than 2% of individuals nationally would have access to the required health resources for this treatment. So once again, the eligibility assessment, that was a big gap for there. And then also on the capacity for infusion services, and then of course the eligibility monitoring requirements through MRIs. So we do rank in Canada along the bottom of countries in terms of MRI availability. And that's something that the system has to take a look at. In terms of infusion capacity, so this IV infusion component, there's a strong presence of private infusion providers that are in the provinces and territories. However, we have to take a look at the medication and whether or not the clinicians would like to have the initial treatment provided within the hospital system for observation. And then, of course, how do you monitor someone as you go along? But it's not all doom and gloom, even though I'm going to go through this workforce and training. You know, while we do have measurable supply gap of professionals out there, On the flip side, we have different methods where we can gain some capacity in the healthcare system. So increasing the scope of providers that can help out, perhaps with other diseases in the healthcare system is one of them. As I mentioned, you can buy an MRI machine, but you still need to train staff for it and act on the results. And you take a look at the current capacity, and we'd probably need thousands of specialist hours, so to speak, to meet early demand. But as I mentioned, it's not all doom and gloom in there. We recognize that there's multiple touch points in the healthcare system that's needed to work with individuals who have early Alzheimer's and all that. Sunnybrook Hospital there, they completed the first infusion of one of these therapies, and they're looking at developing a phased community integrated approach with what they're calling it. Basically, how can we have the care pathway in the out in the community so that all the different healthcare professionals that have the different touch points with individuals, where they get directed to the proper resources in a timely manner. So what a lot of provinces will be looking at in different programs is how can you sort of scale and spread what Sunnybrook's doing in anticipation of these treatments coming along. Another question that comes up is on equity of access. Um, you know, access won't be equal unless the system designs it that way. Uh, rural patients, Indigenous communities, people without a regular family doctor, they all face extra hurdles. But equity doesn't mean that everyone gets treated on day one or necessarily have all the treatment supports where they are. So in the Canada Health Act, for instance, it says, and the Canada Health Act sets up how provinces get funding from the federal government for part of their healthcare costs. But it's what's called where is or and as is in terms of access to treatments and specialists. So the expectation is that there isn't like a neurosurgeon in every small town. If you take a look at Canada's geography, it's intuitive. We see that there's major population corridors all the way from BC into Ontario and the Atlantic provinces. However, there are individuals who are living out in rural places. So, for me, what equitable access means in practice is that everyone is operating underneath the same clinical criteria. There might be different delivery models where you may receive, like, let's say, telehealth services in the community, support for travel, navigation, and caregivers to assess or to help individuals. And then, of course, transparent monitoring of who's accessing the care and who isn't. So, once again, I think it'll be less so on the drug coverage and how you're eligible for it, but more importantly on that care pathway and how does all the communities and how the health providers work together. That's going to be very important, and that's why there's a lot of interest in what Sunnybrook is doing right now. So probably a big question out there is when can we get access and what does that look like? And right now, the drug is with our independent experts. That second phase after Health Canada, the Canadian Drug Agency, and INIS to have a look at it. The Canadian Drug Agency, their expert committee was meeting on this drug yesterday on the 28th. There's going to be draft recommendations put out to go to the sponsor, what they call the drug company, in February. And the draft recommendation will be posted for everyone and for feedback on February 19th. So if you go into Google, I don't have the web address up here, you can actually take a look at the progress of the review of the medication. Right now, what's posted online is the patient and clinician input into the whole process. And as I mentioned, there's a patient member represents, and they're supposed to represent the patient interest and has experience as a patient or caregiver and interested in all these issues. What the experts are deliberating behind the scenes is, we tend to focus on clearly defined patients who could benefit from the technology. But what provinces have to also consider is, account for the unknown patients whose care might be delayed or canceled, basically to pay for these new technologies. And that's not only in the Alzheimer's space, but also happens in the cancer space, where provinces haven't necessarily funded all the new cancer drugs coming along. So the provinces will have the final decision on drug coverage within their own province. They'll do joint negotiations with the company, and individuals are looking for timelines on that. So after that feedback period, March 5th, we should see the final recommendation from our Canadian Drug Agency on this medication in terms of eligibility and what they call cost effectiveness for the medication. Then it goes on to that Pan-Canadian Pharmaceutical Alliance. The Pan-Canadian Pharmaceutical Alliance, once again, is the group of provinces and territories that get together for joint negotiations. Their total timeline on average, it's improved over the last few years from 11 months to 6.5 months now. And once again, that's average. I've seen things as quick as 6 weeks to other files that are still outstanding. Then, once again, it goes for provinces and territories to make that final decisions. If we take a look at one of the older medications that have been out there, and once again, this is pre-Pan-Canadian Pharmaceutical Alliance, before we did joint reviews and all that. It took 2 to 10 years to get a medication, and that was variable listed in individual provinces. And that's from the time that it was submitted to Health Canada for approval to when the government actually provided funding. So once again, there's been efficiencies in the system, and hopefully we can see a good turnaround time and improvement on funding decisions. Also, what we experienced with some of these treatments was there was that need for novel advocacy and investment into the Alzheimer's space, and that's also a requirement in this case too, particularly when it comes to looking at those care pathways and MRIs that we'll need for access. Part of the problems that we also, I wouldn't say problems, part of the challenge that we had or opportunity was when to stop these medications. At what point would you see that individual is no longer getting a benefit? And that's often a hard conversation that our clinicians have with individuals. And one thing that I know or governments will be taking a look at in terms of when do you continue funding a medication and when would you stop it? Early diagnosis is a key, as we've been pointing out, infusion, ongoing monitoring, of course, through during the infusions, and then if there needs to be follow-up MRI, if there's suspect of a blame read and all that, we'll also have to take into consideration. So that's at a high level. I know on the government approval process and timelines for approvals. I'll turn it over to our hosts here for our next section.
Thanks so much, Chad. So our next speakers will be Kara and Paul from our Lived Experience Council. So if you guys would like to take a few minutes to share any thoughts and questions with the group from your perspective, that would be wonderful.
Thank you. Can you take the slide down, please? And can you feature me instead of Carmela? Yay! Hello, everyone, and thank you for coming today. My name is Kara Sullivan, and in 2017, I became a caregiver for my sister-in-law with young onset Alzheimer's. From that time, one of her siblings and I took part in a series of clinical trials, and we discovered in 2020 that this sibling was at an elevated risk for developing Alzheimer's. In 2023, this sibling qualified for the AHEAD study on the effects of lecanemab on people who have elevated amyloid and tau, but have no signs of dementia. So that for people who are in the preclinical stage. And I became their study partner. We've been in the study for 2 years. They continue to score perfect on the MoCA and have exhibited no side effects. So they may be on the placebo. We like to know what kind of extension of cognitive health might lecanemab give a healthy brain with only preclinical Alzheimer's. That is, the presence of amyloid and tau, but no cognitive impairment. And some news that I've read says it only gives people a few months. I didn't realize that it could count for up to a year. But I recently read something from Eisai, the drug company, that suggested it could be as much as 8 years. So I'm curious about that. How does this work for someone who has amyloid and tau but no cognitive impairment? How much more time might one be buying by being on lecanemab? Wouldn't that depend on the amount of amyloid and tau that have accumulated? And I'm reminded again from Dr. Tartaglia that it's spinal taps and PET scans that will measure the amount of amyloid and tau in the system. But these are not paid for by OHIP in Ontario. Though if you join a clinical trial, you can get them, but then they may not disclose the results. That may be a condition of being in the clinical trial. So anyhow, given that Health Canada hasn't approved lecanemab for asymptomatic people, let alone that OHIP doesn't cover it for anything, the good thing about joining the AHEAD study is that it's one way of getting a 50% chance of getting lecanemab. And the drug companies Eisai's being, I think, very generous. If you sign up for their extension period, like, don't get me wrong, being in a study for 4 years, and we don't live in Toronto, we live 2 hours north of Toronto. So, driving back and forth, and for the first 2 years, it was every 2 weeks, and they cover our gas, and they give us food, but it's a big commitment. But down the line, if you stay in the study, then Eisai will give you the drug for free. So being in a study is great in certain ways, that you get advice and attention to help allay or face your fears, and you get a virtuous feeling helping out science. We got a lot of help from the Alzheimer Society in managing my sister-in-law's life. And this is one way that we feel we can give meaning to her suffering and ours. Thank you very much.
Thank you. Do you want me to answer the questions, or should we have Paul also chat, give his story?
I think it would be okay to answer Kara's couple of questions, and then we can have Paul speak.
Oh no, please, Paul is ready with his spiel. So
okay, perfect. So Paul, if you're ready,
everybody has 100 questions in the chat, and my questions are about people who are healthy, not people who are already exhibiting, and that's more of what this. I mean, the Dementia Network Match Me to a Study is great, folks. Sign up there.
Thank you, Kara.
Good afternoon, everybody. In 2010, I suffered a massive stroke, which literally killed the corner of my brain. I eventually ended up being diagnosed with vascular dementia. And for 6 years, life was hell. The psychiatrist that diagnosed me never gave me any referrals, no one to talk to, no one to help me. The only one that helped me was my daughter. and that put a big strain on her. One of my pet peeves is the referral system. When you're diagnosed, you have to be able to talk to someone, get answers. And fortunately for me, I'm a type person, I don't like the word no, and I don't like the words can't do. So for 6 years, I dedicated myself to working and exercising my brain, uh, doing crossword puzzles and word search and anything that would work my brain. And in 2019, I guess I was sort of given a new diagnosis to a point where I just had a vascular cognitive. Um, I live alone. I handle all my own finances. If I am out and about, I use Google Map to help me navigate. Um, I'm pretty lucky I have a pretty good network to help me out. And I live well, and tech is a big part of my life. So, any questions?
There's any questions for Paul?
By the way, this hat, the hat band, is the Forget-Me-Not flower, which Alzheimer Society should be familiar with. And this hat is my signature. If you want, I have a website, and it's pauldlee.com. And you can see my story, my history, all the affiliations I have, what I'm all about.
Thank you so much, Paul.
My pleasure.
And MCP 19 thanks you for your courage and your generosity. So I guess there's a few questions. I don't know. I know it's 1:02, but I'm happy to stay and answer as many as we can get through. Maybe
Help read them out for you. And just for those who are here, I will include the question portion as part of the recording in case people do have to step away and they have their questions. So a lot of these are for you, Dr. Tartaglia. The first one is, at what point in taking lecanemab should one expect the side effects to appear? Yep.
very early on. So most of the side effects, like the brain bleeds and the swelling that I spoke about, they usually happen within the first 6 to 9 months, up to 12 months. But after that, we don't see really these anymore. And so the thinking is that we could probably, do less, we do less monitoring as time goes on. And that's where you see a bunch of MRIs all at the very beginning. And that's because that's where you see most of the side effects. Infusion reactions, which is what I was talking about, when you get an infusion, everybody's at risk of reaction. Those can happen, I guess, at any time. Sometimes, if let's say we knew you would get a rash, then we could give you something before the infusion to prevent the reaction. But a lot of the ones that are big worrisome ones, like the bleed and the edema, the swelling, are in the first few months of taking the drug.
So the next question here is, can someone on antiplatelet medications use lecanemab versus someone who is on anticoagulants would not be able to?
Yes, That is correct. Antiplatelet medications like, a low dose of aspirin is not contraindicated. But and like blood thinning with anticoagulations are like whether it's warfarin or some of these other newer types of blood thinners that you can't take while you're on this drug because that would obviously put you at higher risk of brain bleeding, which is not a good thing.
The next one is really around cognitive tests. They can be very variable. If with good sleep and less stress, you perform so much better. So how do you use imaging and biomarker to categorize MCI or prodromal Alzheimer's disease?
Yeah, that's a great question, and you're correct, and sometimes people score quite badly on the test and they're actually functionally doing very well, and the opposite is also true, high test scores and, poor function. So we do more investigations, and I guess I advocate for investigating when people come to you with cognitive complaints or changes in behavior. I do not believe that somebody who complains of a cough should get more investigation than somebody who complains of a cognitive change or a behavioral change. If your brain changes, you will change, and there should be some investigations for that. So you need imaging. We need to look at your brain. That's where your symptoms come from. CT scans are actually inadequate. They're really good for making sure you don't have a big tumor there or you had a giant stroke, but they're not good enough for really looking at the sizes of the structures very well, for looking at the amount of white matter disease that can happen when people have strokes, but sometimes it happens even when people don't have strokes. We need a brain MRI for that. And then, of course, to know what the cause of your disease is, right? To know what the cause of your cognitive changes are, your memory problems, language problems, we need other things. So there's not actually all the diseases we don't even have tests for, but we have tests for Alzheimer's. So if that is suspected, then people should do more investigations. There are 3 tests that can be done. A lumbar puncture can be done. They actually are used routinely. And in some countries of the world, like if you're in Sweden and you go see somebody about a cognitive problem, if they don't do a lumbar puncture, you could report them and say, that's malpractice. They did not investigate my problem. PET amyloid. So a PET scan is a nuclear scan, and there's not that many across the province, but there are probably 7 or 8 of them that will be able to do PET amyloid. And so that obviously, as Chad said, that's like the province is big. 7 of them is not going to cover the whole province. But some people can have access, and we're rolling out. We have a PET amyloid registry that we started a few years ago, but it was very limited, and we're in the process of rolling that out a little bit better. Blood tests have come to Canada. They are not Health Canada approved, nor are they they're not covered by any of the healthcare systems. The issue with the blood test is most of the data really comes from very well characterized people in studies. And that is not necessarily what happens in the real world. We're only starting to get that evidence from the real world. So the blood tests, I think, are going to take a bigger and bigger role, but I'm not sure they're there for prime time right now. And the other problem for them is that when you want to talk about inequity, they are not covered, so only people who can afford them can take them. They're not super expensive, but still $600, $800 is quite a lot of money.
The next question here is, you've mentioned that Life Labs now has biomarker tests for Alzheimer's disease. Since the pathology can occur decades before symptoms actually appear, how early can these blood tests detect pathology?
They can detect pathology a long time, probably a decade before. The point is that right now in our healthcare system, the way it works is we would only screen, and that's what it's called, when you are screening somebody who has no symptoms, right? The way we screen for, diabetes, or the screen for thyroid problems or vitamin B12 deficiency. You don't have necessarily any problems, but you get screened to make sure you don't have that deficiency. We only do that if there's actually a fix for the problem. So you do colonoscopies, because if you found something, we could try to fix it. Right now, as Kara's mentioned, that person is in a research trial for using this drug for somebody that's asymptomatic. We actually don't know if it's going to work, right? Like the evidence that we have right now is that if you have mild symptoms, it does work. And there is data that if you get people who have very, very low amyloid, that you can actually delay disease by 8 years, right? But that is still in kind of the infancy. The solid data out there is that if you have mild disease, you take these drugs, they can slow down the progression. That's what we're working with. One day, when we have drugs that will stop this disease, then we will screen people. And of course, then you would give the drug before they even show any symptoms. Why would you wait? But we're not there yet. So right now, having a positive test, I think will mostly only give a person anxiety. And I'm not sure, we all know anxiety is really bad for cognition. So I'm certain that if you had a positive test and you had no symptoms before, you will have symptoms after of anxiety and poor memory. So we're not really promoting that at all.
Two-parter here. So since lecanemab removes amyloid earlier than, can't pronounce this, but donanemab, would
Yeah.
you, would you expect lecanemab to perform better? And then the second part is, are you aware of any drug research focusing on removing tau?
Yeah, I think the question of donanemab versus lecanemab, they both remove amyloid. They do it really, really well. There's not really much difference in terms of how they remove it. Donanemab does it so quickly that in the drug trial, they actually had stopped giving donanemab, and the amyloid was still very low. So I don't, those are the questions you can answer when you do these drug trials where, you put two drugs against each other and it's a race, right? And see which one does better. So I can't answer that. They both do it, and they both do it in different ways. And once donanemab gets approved, if, hopefully it does, then, it'll be somebody's choice on which one they would like. In terms of drug trials for tau, actually there are a number of course it makes sense to go after tau, right? Like the second bad protein, it's actually the protein that dictates more how somebody does. So there are a number of drug trials, but to date, nothing has worked to get to in removing the tau and, making a difference. But like that pie chart that I showed that had all those colors, there's a bunch of them actually that are aimed against tau.
This question is around genetics. So could you comment on whether Alzheimer's is an inherited disease?
Yeah, so I mean that's a great question, but so when we say genetic, so I was talking about ApoE. ApoE is not what we would consider a genetic disease because having ApoE just increases your possibility. But there are some genes, like if you have an APP mutation or presenilin 1 and 2 mutation, then you have the genetic form of Alzheimer's disease. And it is there, right? There are huge families that have lots of people who are in their 40s, 50s years old, they have Alzheimer's disease, and the children and the siblings and the parents all have Alzheimer's. But that actually is quite rare. We actually have pockets of these families, a big one in Colombia. There's, a few places in the world. So that's why people say, Alzheimer's disease has a less of, is not a genetic disease. When you think of things like frontotemporal lobar degeneration, where, 20% you find the gene, 40% have strong family histories. Of course, that's very different. We're talking about less than 5%. We're talking closer to 1%. So it is true that we don't think of, Alzheimer's as being genetic. And when we think of family history, of course, sometimes people are very fortunate because everybody in their family lived to a very old age. And of course, age is the biggest risk factor for Alzheimer's. So it does sometimes seem like, oh wow, everybody, that person has a lot of family members who've had Alzheimer's disease. So it's not so easy to answer. But when you think of all diseases, all diseases are really a interaction between you and the genes that make you and your environment, right? And so, will there be more research to show that there are, like, not one gene, but maybe genetic combinations that put people at risk? Yes, it's possible. And of course, those genetic combinations may travel together in a family. So we have so much more to learn, right? And so, but we can't just go with, yes, I have, like, they have many family members, because you have to really look at what, the ages of the people, what age they got the disease. The other thing too is that sometimes it's not Alzheimer's disease, right? I showed you that other pie chart that showed Alzheimer's is 40%, in some cohorts it's like 50 or 60, but it's not 100%. And a lot of people, unfortunately, are getting a diagnosis of Alzheimer's, but it's a misdiagnosis. They had something else. Hope that answers that.
Next question is around tau. So p-tau 217 rises with normal aging. Is this a false biomarker? Could it lead to misdiagnosis?
Yeah, it's a blood biomarker. It does increase with age, but so do all biomarkers. Most of them, are affected by age. I mean, the studies that have been done on them are quite large, right, across, fairly decent age ranges, and it did pretty well, right? And when we check those people that P217 said have, Alzheimer's or amyloid, when we check their PET amyloid and their cerebrospinal fluid amyloid, they had it. So I would say it's pretty good. I don't know if, it's so good that I would give a treatment like lecanemab based on a blood biomarker. I'm not there, but it's a pretty good test. And, if it became available, it might be a good test for screening people who, maybe fit the criteria, like they have mild changes, they might have early dementia, but do they want to do a lumbar puncture? Do they want to get a PET scan? Well, maybe that's not available readily. Maybe we start with that. So it will fit, somewhere in this patient journey to getting these disease modifying therapies. But, there are like a few kinks to work out first, like it not being covered is a problem. But yeah, you shouldn't get too many false positives because of age.
So at the Alzheimer conference last summer, research was shared that amyloid beta proteins and tau protein abnormalities were measured in blood and can precede the onset of clinical symptoms by up to 10 years. The question is really, why aren't these biomarkers being used right now to provide baseline values and screen and monitor possible early disease in otherwise healthy citizens?
Yeah, and as I mentioned before, that, when we have a treatment that is going to be, not like a treatment that will really change, like, stop the disease, something like what we do when we see, when we have somebody be positive in, a colonoscopy or, mammogram, where we do things. I think then it will make sense to do that. But right now, we wouldn't give this drug unless you have mild symptoms, right? So you have to have the symptoms. That's where it should start. You should be investigated for the symptoms that you have, because we're not at a point in time where we can screen people and give them something. We have, we give everybody the advice that they should do all the right things for their brain health, but you should do that anyways, right? It's important to exercise. It's important to learn new things every day, to eat a balanced meal, to avoid alcohol, to avoid smoking, to be social, to make sure your blood pressure is good. All those kinds of interventions, they should be done for everybody. So that shouldn't change if you were P217 positive and you had no symptoms. You should be doing those anyways. But the drugs that we have right now, they are for people who have mild symptoms.
I know the person that asked this may have left earlier, but the question is, what is your response to Dr. Dale Bredson's allegation that amyloid plaques are not the cause, but the brain's ability to protect itself? Therefore, removing amyloid alone doesn't work. You must remove why the brain is making amyloid in the first place.
Well, I think the current data from these two, and actually there was a third drug trial, shows you that, well, amyloid's not great. And removing it is probably a good thing. Is amyloid the whole story? No, we already said that. Amyloid is only half the story. And, you know, the the reason that amyloid becomes sticky and starts to clump together, we don't understand that. Why that clumpy amyloid actually makes your tau go bad, which is what spreads through the brain, we don't really fully understand that. So there's a lot to know. But I guess at the end of the day, do I want amyloid clumps in my brain? No, I do not want them there, because I do believe that something has gone wrong and that they are accumulating for some reason. We make amyloid all the time, but we don't make it like clumpy. So research is like that, right? Research, and that's why we're always grateful that people participate in research, because that's how we learn. That's how we're going to move the needle and understand. And maybe one day we'll be like, okay, who cares about the amyloid? We need to go after this other protein, maybe. But I would say that there is a good amount of evidence that having a lot of amyloid in the brain, and definitely having a lot of tau in the brain, is not good.
This one is in relation to your chocolate analogy. So given that ApoE4 carriers are at higher risk and that there is connection with poor lipid or cholesterol metabolism profiles, plus the fact that metabolic and vascular diseases are risk factors for dementia, why are there not specific titer blood biomarker targets for those chocolate carriers?
I think that's a fantastic question. I think that we need to move towards precision medicine in our world. We use the same standards for females and males for many things, and we know those two sexes are completely different. So you're right. Maybe in the future we will have to have guidance for people who are at higher risk. We actually do have some evidence that if you have the chocolate, you actually should do more physical activity, because the physical activity in the chocolate has a bigger bang for its buck. So, I do think that as our research evolves, we will be more precise, and we will do in neurodegenerative diseases what we do in cancer. In cancer, before we throw any medication at you, and there's a lot of expensive medications in cancer and expensive investigations in cancer, where you don't get anything until you get those expensive investigations, and the monitoring and all that is done because of precision. You could have a big brain tumor and you're going to get imaged over and over and over again. Your lifespan is not even going to get that much bigger. Nobody thinks twice about it, because it's all about precision. It's all about knowing everything about you. And that's important for cancer. My question is always, well, why is it not important for neurodegeneration? Yeah, it's bad to have a big brain tumor in your brain, and a tumor anywhere is very bad. But so is it really bad to have Alzheimer's disease and any of these other neurodegenerative diseases. And why should those people deserve less? Why should they deserve less investigations? Why should they deserve less, treatment because, it's expensive, or monitoring? But great question.
The next one's really more of a comment. I see two comments, both from Kara as well as another participant, that there are significant lifestyle changes that are totally within one's control, can reduce risk. And so I know Kara's also reiterated that. There is one question on a third drug, and I am horrible at pronunciation, so I'm not going to try. But there seems to be another drug, and do we know if it is showing more promise than lecanemab or donanemab? It's pronounced Fonten.
Trontinemab. Yeah, it's another drug and it's, it's still in a trial. So, results are look very promising and we'll see, right? I mean, that's what I was saying. It's like we have every reason to be optimistic. We have every reason to be hopeful. There is a lot of investment in this area. As, Chad actually mentioned, there's tons of people with these diseases, right? So, of course, it makes it a very attractive targets because you're going to be able to help a lot of people. And, there's trontinemab is one drug, but if you look through all the different like that pie chart, there's hundreds of trials going on in different agents, and all of them are at different steps, and in different types of interventions. And the person was asking about amyloid. Well, there's other targets that we're going after. Even outside of amyloid and tau, some of us think inflammation is really important. So we have drugs aimed at inflammation and mitochondria and oxidative stress and metabolism. Nobody, I think we're casting the net wide because we know that there's a lot we don't know yet, and so we do have so much to learn, but we're taking these like small wins that we have and and hoping for more and better ones.
So I want to recognize that it is almost 1:30, and I want to thank everyone for your interest in staying. Clearly, there was a lot of questions that people wanted to know. I wanted to thank all of our speakers, Dr. Tartaglia, Chad, Paul, and Kara, for taking some time to share their knowledge and experience. For all of those who are interested in maybe revisiting everything, because it was a lot of information, again, this video will be posted on both the Alzheimer Society of Toronto's YouTube channel as well as the TDRA site. I will be sending an email with the registration and also where specifically those videos will be found once posted. And I would love to have your feedback in terms of some of the things that you would like to hear about in future. So I hope everyone has a fantastic afternoon and we'll see you at a future session.
Yes, thank you, everybody.
Thanks, everybody.